My background is that I have a clinical background in imaging services, so I kind of feel as if I've got free rein to say what I like about support services, to be honest. And it's a bit kind of how we messed it up, because we did. We completely messed it up. And I guess over the next maybe 20 minutes, it's 12:15, I'm going to try to take us through currently what we've got, probably where we need to be, and a little bit about how we might start getting there. So what do we mean by support services? Well, for any patient going through our organisations, they're going to need access to some clinical support stuff, which might be things like pathology, imaging, therapies, which could be physiotherapy, speech and language therapy, occupational therapy, radiotherapy, etc., or pharmacy. But I thought it would be quite remiss of me not to mention some of the facilities stuff that goes on around the hospital. Things like human resources, healthcare records, might be transport, laundry, or estates. And we need all of these services for their cycle times to come in under TACT, under the rate of patient demand going through the value streams. Because this is what we need. This is what Ken was just talking about. We need it to flow. And all of these support services need to be in sync with that flow. So I'm going to keep sticking to this analogy of this fishbone diagram this afternoon. Currently what we've got is this. They're all doing their own thing. They're all operating in a disconnected mode. And that has a massive impact on flow. What we end up with is this. And that's our big problem. The answer of how we're going to get each rib to work their cycle times under TACT is going to be quite different. But why? Why does it happen? There was a lot of debate yesterday at a meeting that I went to around the way hospitals are set up structurally. And they're set up in kind of vertical department mentality. That's kind of where we are, that's what we've got. They're vertical structures, and we're all really busy. Undoubtedly, people are very, very, very busy. However, they don't see beyond the four walls of where they are. So it looks like that. When we need flow across them, no matter what condition you are as a patient, what value stream, what pathway you might be on, this is what we need. But people get stuck. They get stuck at the interfaces, they get stuck at the barriers, and they kind of get stuck in those departments. That's kind of what happens. And we need everybody working to TACT. For every patient that goes through the hospital. But there isn't really anybody with the eyes across this whole value stream, apart from what Maria's going to talk about this afternoon. And by the way, if you know Maria, this definitely is not her. So we need our patients to flow. Let's get them moving. And I use this fishbone just as an analogy, and I'm going to stick with it for the duration. So we'll move them all along. This is kind of what we need. But this is what happens with support services at the moment. Their cycle times don't come in under TACT. So each of the green lines that you can see coming on, this is where they have probably got it right. But the red lines, they haven't. So some of the time, for some of the patients, we do okay, and they're all right. But for others, we don't. And that happens a lot. These are the patients that wait, they get worse, or they die. We kill them. And we kill them every single day. Why does it happen? Sometimes it's just because the support services aren't available when we need them to be. So we work with a lot of teams, and when we look at their demand data on a Monday, we see big peaks in what they've got. It's actually artificial demand. It's not real. If we counted when the demand really occurred on a Saturday and Sunday, but we weren't there to do it, we'd see that actually things are pretty level across the week. And you could probably do this with a lot of demand data. Our own practices in the days that we are available in support services often create an awful lot of variability. And this is a kind of representation of a scheduling system. Now, this was actually a scanning system, but it could be any support service. All of these, every one of these is a 15-minute block. So here, on a Monday, we've got 4 hours worth of outpatient orthopaedic referrals coming in that are going to be done soon. And that's when they've set up their schedules. So they've kind of batched patients according to either body part that they want to investigate or condition. And you can have a look through, flick through each of the days if you like. But we've done that based on making our schedules work around the individual professional or the individual team. And it's not based on proper demand data for patients. So if you're an inpatient and you're suspected of having cancer in this system, the only day that you could possibly get a slot would be a Tuesday afternoon. And this is the chaos it causes. So this is data, again, from a site. And this is consecutively referred in patients along the bottom, and the number of days, obviously, that they kept waiting. And it looks as though, well, for inpatients, it's bumbling about at the bottom and it's not doing too bad. But actually, it's just as chaotic. If we blow it up, this is what it looks like. And based on the scheduling system I've just showed you, actually, it's not surprising. It's really not surprising. If you were referred in to that service as a cancer patient on a Wednesday morning, the chances are you wouldn't get your scan until Tuesday afternoon of the following week. And we justify that. So, back to this analogy of all our patients in flow. What do? We've set up these systems and they don't work. So we start to prioritise. We start to do this. We start firefighting our patients through the systems. We batch them. We push them through. There is no first in, first out, not even for elective patients. And this is kind of how it feels. As a patient, it's just eeny, meeny, miny, mo. We're all coming in to do our best, probably, at work. But the best that what we can do isn't good enough. We've got to do what needs to be done. However, I don't think that anybody comes into work with the intention of deliberately getting it wrong. Systems have kind of evolved over time. They're uncoordinated, and we've got these vertically constructed organisations all set up. And wards have to share the support services, but the support services don't really understand what the demand is from all of these wards. So, for example, a visiting physiotherapist going to multiple wards might not have the time to chase a patient who was unavailable on the time that that professional visited. So that patient might miss out on rehab that day. Now, if that's a neuro patient who was learning to walk and missed their physiotherapy on a Friday, services are unavailable Saturday, Sunday, and if they were lucky enough to get a slot on a Monday, they'd have lost 3 days of rehab. If the swallowing reflex isn't assessed by a speech and language therapist, the patient will just aspirate. That'll lead to further complications or even a fatality. If the porter arrives on the ward and the patient's gone to the bathroom, so they're not available to be taken for a scan or intervention, they simply miss their slot. And some of it, like Ken said, he used the word, it's not rocket science, it's not, we just need to think about it. A porter makes all the difference to support services, and certainly to the efficiency of running support services. But the problem I think that we have a lot of the time is we need them to be run like a black cab service. So it's, I want one, can I have one? And we set them up, the norm in our hospitals is to set them up like a mini cab service. That's what we do. So you have to book ahead, and that interrupts flow. And all of this uncoordination that we seem to have between the tests, the treatments, the results and the reviews, it makes it so that actually we get delayed discharge because things are not available for the ward rounds. That leads to further problems because we then have the bed management teams coming in, they can't move patients out, and there's still patients coming into the hospital and they get inappropriately placed on wards, and that adds to further clinical risk. So, back to this again. We need all our support services to respond to every patient, no matter what their diagnosis, their condition, or their value stream. And the kind of question is, well, how? So, I've already said before, and Ken alluded to this and so did Mark earlier, that each of these support services need to come in under TACT. Their cycle times need to be under what the demand is for patients coming through. So, is it possible to think about co-locating departments, so that processes are further together? Like, could you put histopathology right next door to theatres? Is that such radical thinking? Not really. What about putting imaging into orthopaedics or ultrasound into A&E? Whatever you do, you've got to get your cycle times down. And I guess to take us through all of that would take us probably the rest of the afternoon. So I'm just going to pick one area. And because this is my background and I've still got probably 10 minutes, it's my party, we're going to look at imaging. So, like Mark showed you earlier, you would probably first off start to pull together a demand map of where patients are coming from and where they're going to in and out of these support services. But for simplicity, I've tried to just pull together some data of, and this is demand for a CT scanner, and this is per week. And this is kind of how it breaks down. So, can we break that down into daily demand? And then can we start to look at it hour by hour? So what you'd start to do, your first step is to plot out your current availability. Let's look at the working day, and let's look at where demand is actually coming from. And how much have we been asked to do? And then it's just a case of plotting the numbers. So across the rows, down the rows. I'll just fill them all in for you. It's a bit like playing Sudoku. Not that I do. But that's just what it's like. And it's not about reducing turnaround times all the time. Ultimately, yes, we need flow. But if we just consider back to what we saw in that scheduling system where patients were booked every 15 minutes. In this system, between 8 and 10, so each of the columns basically are 2 hours slots, and we know that of what we need to do in each of those 2 hours. We know we can scan 8 patients in 2 hours on one machine, and we've got 2 scanners. And all we've been asked to do is 14 patients. So we could have done 16, we've been asked to do 14. So we're not actually asking anyone to work any harder or faster. But yes, we are actually asking them to mix up the case mix, if you like. So this might be the map across a department. What we need to have a look at is what needs to be done in sequence, what timings do we need, what are the trigger points of stuff, and what are the volumes in demand. Where can we actually get rid of some of these weights? And where can we eliminate these triangles? Where might we be able to put in some work cells? And where might we have to set up some rules around temporary managed waiting systems? And ultimately, how are we going to initiate pull? The key to designing the future state is in sex. So simplify, eliminate, combine and sequence. Where can we eliminate the triangles? And what can we do when we can't? So remember, the triangles are the bits in between. So if we can combine and simplify processes as much as we can, we're going to get rid of them. Some parts of the process might actually need to slow down in order to speed up the whole. So reporting went from being probably 5 minutes to being a good sort of 12. But actually we've eliminated the stops and starts and the toing and froing and the handoffs to secretarial staff and back to consultants in between time. And then the aim, obviously, would be to reduce our cycle times. So the key to understanding what you've got is literally plotting it out and working towards what you need to do. I think the problem that we might have is that for some of the support services, once we start doing this in these kind of vertical structures that we've got, any improvements that we make, we're going to need some really good communication across the whole organisation, because there will be ramifications between knock-on departments and through the value stream. So, if we can map demand and level our schedules for every support service and reduce cycle times, set up some work cells where we can, we should get patients flowing through the value stream. So this could be the working support services. And no matter what patient presents, in what order it presents in, we should be able to get them flow. I'm just going to simulate what it does. So here's our cardiology patient going through the process. And at every stage, it's able to pull the service that it requires from support services all the way along the line. And we can do that for every patient going through. The key probably message I would say is that support services should not be setting their own turnaround times. They need to work at the speed of patient demand. It's not good enough for patients to ration their services. So we'll just speed all these through. And hopefully they'll hit every time, whether it be a urology patient, stroke patient, respiratory, or neuro. And that's kind of where we can put the future of our support services back into where Mark showed us this morning, into the future state map. But it's going to take us to think very differently about this. The results that we've seen within departments are absolutely enormous, but we do need to see it across the whole service, because if not, we'll still be processing waste at the boundaries. That's what will happen. So the key message is we've got to see through those boundaries, and we've got to see through them quickly. We've got to get staff over themselves, really, in their own departments, and get our patients to get through those walls. And we might need to do that fairly step by step. But really, it comes back to what Ken was talking about with the plan, do, study, act cycles. And I would urge you just to have a go. And we're not going to get it all right, and we're certainly not going to get it all right at once. But actually, our best hope of saving lives for patients is not just in the clinical judgments and the clinical decision-making that we make. It's actually in raising our own performance.